Sensitivity and specificity. Positive test: A true positive, B false positive. Negative test: C false negative, D true negative. Sensitivity is equal A divided by A plus C into 100. Specificity is equal D divided by D plus B into 100. Figure 1.4: Receiver operating characteristic graph illustrating the trade-off between sensitivity and specificity for a given test. The curve is generated by adjusting the cutoff values, defining normal and abnormal results, calculating the effect on sensitivity and specificity, and then plotting this against each other. The closer the curve lies to the top left hand corner, the more useful the test. The red line illustrates a test with useful discriminant value, and the green line illustrates a less useful, poorly discriminant test. Hip movement and is able to bear weight, then the clinical probability of hip fracture is low. Doctors are continually making judgments about whether something is true given that something else is true. This is known as conditional probability. Bayes' theorem, named after English clergyman Thomas Bayes, 1702 to 1761, is a mathematical way to describe the post-test probability of a disease by combining pre-test probability, sensitivity, and specificity. In clinical practice, doctors are not able to make complex mathematical calculations for every decision they make. In practical terms, the answer to the question of whether there is a fracture is that in a high probability patient, a normal test result does not exclude it, but in a low probability patient, virtually does. This principle is illustrated in figure 1.5. Sox and colleagues, see further information, state a fundamental assertion which they describe as a profound and subtle principle of clinical medicine. The interpretation of new information depends on what you believed beforehand. In other words, the interpretation of a test result depends on the probability of disease before the test. Prevalence of disease. Consider this problem that was posted to a group of Harvard doctors. The problem originates from a 1978 article in the New England Journal of Medicine. If a test to detect a disease whose prevalence is 1 is to 1000 has a false positive rate of 5%, what is the chance that a person found to have a positive result actually has the disease? Assuming you know nothing about the person's symptoms and signs, assume the test generates no false negatives and take a moment to work this out. In this problem, we have removed clinical probability and are only considering prevalence. The answer is at the end of chapter, page 11. Predictive values combine sensitivity, specificity, and prevalence. Sensitivity and specificity are characteristics of the test. The population does not change this. However, as doctors, we are interested in the question, why is the probability that a person with a positive test actually has the disease? This is illustrated in box 1.5. Post-test probability and predictive values are different. Post-test probability is the probability of a disease after taking into account new information from a test result. Bayes' theorem can be used to calculate post-test probability for a patient in any population. The pre-test probability of disease is decided by the doctor. It is a judgment based on information gathered prior to ordering the test. Predictive value is the proportion of patients with a test result who have the disease or no disease and is calculated from a table of results in a specific population. See box 1.5. It is not possible to transfer this value to a different population. This is important to realize because published information about the performance of diagnostic tests may not apply to different populations. In deciding the pre-test probability of disease, clinicians often neglect to take prevalence into account, and this distorts their estimate of probability. To estimate the probability of disease in a patient more accurately, clinicians should anchor on the prevalence of disease in the subgroup to which the patient belongs and then adjust to take the individual factors into account. Dealing with uncertainty. Clinical findings are imperfect and diagnostic tests are imperfect. It is important to recognize that clinicians frequently deal with uncertainty. By expressing uncertainty as probability, new information from diagnostic tests can be incorporated more accurately. However, subjective estimates of probability can sometimes be unreliable. As the section on cognitive biases will demonstrate, intuition can be a source of error. Knowing the patient's true state is often unnecessary in clinical decision making. Socks and colleagues argue that there is a difference between knowing that a disease is present and acting as if it were present. The requirement for diagnostic certainty depends on the penalty for being wrong. Different situations require different levels of certainty before starting treatment. How we communicate uncertainty to patients will be discussed later in this chapter. See figure 1.9. The treatment threshold combines factors such as the risks of the test and the risks versus benefits of treatment. The point at which the factors are all evenly weighted is the threshold. If a test or treatment for a disease is effective and low risk, example giving antibiotics for a suspected urinary tract infection, then there is a lower threshold for going ahead. On the other hand, if a test or treatment is less effective or high risk, example starting chemotherapy for a malignant brain tumor, then greater confidence is required in the clinical diagnosis and potential benefits of treatment first. In principle, if a diagnostic test will not change the management of the patient, then careful consideration should be given to whether it is necessary to do the test at all. In summary, test results shift our thinking but rarely give a yes or a no answer in terms of diagnosis. Sometimes tests shift the probability of disease by less than we realize. Pre-test probability is key, and this is derived from the history and physical examination combined with a sound knowledge of medicine and an understanding of the prevalence of disease in the particular care setting or the population to which the patient belongs. Problem representation. Many students are taught to formulate a differential diagnosis after the history, physical examination, and initial test results. But the ability to accurately articulate a problem representation or problem list first and then construct a prioritized differential diagnosis based on this, including relevant must not miss diagnoses, is a key step in clinical reasoning process. A problem representation refers to how information about a problem is mentally organized. Studies show that expert clinicians spend far more time on defining a problem before trying to solve it with compared with novices, and novices are more likely to be unsuccessful in solving